Hey y'all, welcome back. Elvis says hello. Uh, Congratulations, you have made it through the midterm point. And really excited to get back into it this week with you. We are getting into two classes of the DSM that represent conditions of human suffering that have been highlighted in the popular discourse during the last few decades, for better and for worse. I'm, of course, referencing obsessive compulsive and related disorders, as well as these stressor and trauma, or excuse me, I should say trauma and stressor related disorders. And this is, of course, for the better because media like movies, television shows, stand-up comedy, social media have brought awareness to these two classes in a way that has alerted the general public to the reality that this type of human suffering really does exist, and has sort of personalized it, as you have probably noticed by now. I am a big fan of putting really kind of skin on sort of the things we're discussing in the DSM, as it will relate to helping you become a strong, observant, and have good critical thinking in terms of your clinical skills. Of course, we're going to cover in this video the obsessive compulsive and related disorders. The popularization of this class has been very helpful for just the improving awareness, and when it goes well, sort of enhancing compassion, improving skill by which clinicians provide care, as well as for lay people to have compassion and to provide support for their loved ones who may be suffering with these symptoms. Of course, there's the other side of that coin too, right? Just like with everything, the popularization has in some ways been done in ways that sort of defeat that compassionate purpose. So stigma in some ways has worsened, especially for those with problems with things like hoarding disorder, trichotillomania, or excoriation disorder. And so the seriousness has in some ways been diluted. In our popular discourse, I think it's safe to say that when a person says that they have OCD, or they may sort of make a passing comment like that, I'm kind of OCD about X or Y, while their thinking and behavior may resemble obsessions or compulsions, they probably don't meet full DSM criteria for these conditions. And so this matters because it runs the risk of diverting attention and resources from people who are suffering to a greater degree. It also runs the risk of providing sort of over treatment for a person, especially considering that some psychotropic medication, especially SSRIs, which are prescribed to treat OCD, they're usually prescribed in higher doses. When treating someone who meets criteria for depression or an anxiety disorder, higher doses than when treating with someone with a more common use like depression or anxiety disorders for SSRIs. It may also skew the perspective, that is sort of cause a clinician to lean toward referring for psychiatry when psychotherapy, such as cognitive behavioral therapy, mindfulness-based interventions, acceptance and commitment therapy, or ACT, you may have heard described that way. Psychotherapy may suffice without introducing new chemicals to the brain. So like always, please pay close attention to the details and the diagnostic criteria, especially when it comes to the number of criteria met, the duration of the episodes and the severity of impairment to a person's functioning when you're considering whether or not a person meets diagnostic criteria, as it serves the purpose of preparing for treatment and planning, making treatment plans. So, excuse me, the unifying theme of the obsessive compulsive and related disorders class is sort of patterns, cognitive patterns and or behavioral patterns, so thinking or behavior, that are intrusive, preoccupying, distressing, and interfering with a person's day-to-day functioning and are developmentally inappropriate. Of course, these patterns typically show up as obsessions or compulsions, which are defined clearly for you in the DSM. These patterns are often fueled by anxiety and could be considered a sort of manifestation of attempts to create order in a existence or environment that feels chaotic or out of control to the person. Now, in the obsessive compulsive and related disorders class are obsessive compulsive disorder, which is characterized by these DSM defined obsessions and or compulsions. Keep in mind, only one. Obsessions or compulsions are required for diagnosis. And of course, the vast majority of people will present with both because they are closely related, typically. So people must sort of meet criteria for a DSM-defined obsession and or compulsion. There must be a significant sort of element of these obsessions and compulsions consuming the person's time, typically more than an hour a day, or otherwise impair functioning. So maybe a person is sort of caught up and preoccupied by their obsessions and or compulsions to the degree that they either don't go to work or cannot maintain employment or maintain status in an academic program. They may suffer from worsened social isolation. They may be suffering from debilitating emotional dysregulation, etc. Now, as you might imagine, again, the DSM allows for other types of impairment or reasons that a person's social, occupational, academic, and psychological functioning will be impaired, but more often than not, vastly more often than not, the reason that these obsessions and compulsions impair functioning are related to this sort of consumption of time. So a person is perhaps unable to leave their home on time for work and put their job status at risk because they get stuck checking locks for an hour or more at a time. They may be on the way to work and feel compelled to circle back on their routes because they feel compelled to check on some minute detail in their commute. This is the type of thing that is sort of common for a person dealing with OCD. Secondly, in the class is body dysmorphic disorder. So this is characterized by preoccupation with one or more perceived physical flaws or defects. For example, the size of a person's nose, the color of their eyes, the length of their arms, the composition of their muscular structure and size. And this preoccupation with these flaws appears slight at worst to a consensus of others, coupled with compulsive mental or physical behavior. So again, I'll repeat that. That was sort of jumbled. Body dysmorphic disorder is characterized by a preoccupation with one or more perceived physical flaws or defects that appear as slight, at worst, to a consensus of others. And this preoccupation is coupled with compulsive mental or physical behavior. For example, comparing self to others, frequent reassurance seeking, checking the mirror. You get the idea. And so people who suffer with this may compulsively seek cosmetic surgery. This is one of the places where, excuse me, one of the places where stigma has really sort of served a negative, well, popularization has served a negative purpose in terms of worsening stigma. You may have seen articles in media that portray people with severe sort of deformations as a result of compulsively seeking plastic surgery or cosmetic surgery. So that's one way in which stigma has worsened around body dysmorphic disorder. It's also important to note that when it comes to body dysmorphic disorder, comorbid substance use disorders, which are typically considered like, alcohol use disorder, opioid use disorder, cannabis use disorder. These comorbid substance use disorders may also include the use of body or performance enhancing drugs like anabolic steroids. So you might run into body dysmorphic disorder in a bodybuilding or athletic community. And that sort of is the setting in which the symptoms proliferate and worsen to the point where a person's putting their long-term health at risk because they're putting anabolic steroids or other performance enhancing hormones like testosterone in their body. So thirdly in the class is another sort of popularized and stigmatized disorder known as hoarding disorder. This is characterized by persistent difficulty discarding or parting with possessions, regardless of the objective actual value of those possessions. Other characteristics include thoughts of discarding these items are distressing to a person in a way that is debilitating. Living areas are typically compromised, and there is impairment of functioning that likely includes risk to a person or their their dependent's safety. So again, I'll read that and go over that one more time. So this is characterized by persistent difficulty discarding or parting with possessions, regardless of the possession's value. This is often characterized by thoughts of discarding these items are distressing to a person. The living areas of the person are often compromised because of the inability to part with possessions, and impairment of functioning going beyond sort of the typical difficulties with employment, academics, or social connections, other cognitive, emotional, and behavioral functioning. In addition to that, a person may have sort of increased risk to their safety and or the safety of others in their environment, usually people who are considered dependents. So an example may be a person may have such a cluttered living space that exits to that space are blocked, putting safety at risk in the event of a house fire. Okay, so those are sort of the sort of three most common and popularized examples of obsessive compulsive and related disorders. In this class are also included what you may have heard is called trichotillomania or hair pulling disorder and excoriation disorder or skin picking disorder. These are closely related, as you might imagine. So trichotillomania is characterized by recurrent pulling of hair resulting in hair loss coupled with attempts to decrease or stop the behavior. Women are far more frequently affected than men by a ratio of 10-1, according to the DSM-5-TR. And it most frequently follows the onset of puberty. So people may be pulling out hair that develops during the course of puberty, but they also may be pulling hair that is sort of been present their whole life. So they pull hair out of their head and things of that nature. Excoriation disorder is very similar in that instead of pulling hair, it is essentially the picking of skin. With attempts to stop, this is important to note that this must be distressing enough for the person that they want to stop. And it often starts again, just like trichotillomania, in adolescence, following the onset of puberty. And it often begins with a dermatological condition. So maybe a person is dealing with acne, or I'm blanking on a couple of the more popular or well-known skin or dermatological illnesses. But hopefully you get the idea that a person is trying to address this dermatological condition in a way that ultimately causes harm to them, is sort of self-defeating. This goes, of course, beyond. I mean, we certainly remove hair especially in our culture, our Western culture, in a way that is not understood as disordered, although there perhaps are well-founded arguments that it is not really serving ourselves well to do that. Again, this typically leads to increased suffering for the person, to the point that they recognize the suffering and they try to stop, but they feel compelled to continue the behavior. So let's get into a bit of a case example so that, again, we can put some skin on it, personalize the condition for you. I will share my screen and we will take a quick look at the case example of Cindy. So as we have said before, as we mentioned before, please make sure you take a look at the case example that has been posted for you underneath this video. If you have not done that yet, please do so now. Pause the video and go through it now. And as you come back, you'll remember that Cindy identifies as a 46-year-old cisgender divorced biracial woman who is the mother of 3 older children. She is intelligent, insightful, determined, creative, and musically inclined. Just kind of getting at some of her strengths there that might endear her to you as the clinician, as well as those around her in her social environment. Cindy presented as motivated to be successful in the future and seemed ready for treatment and change. She is a loving and caring mother for her children, and this seems to be an essential part of her identity. Cindy historically has had close ties to her church, where she attended services regularly and played the organ and piano for the congregation. She's optimistic that she will increase her involvement with her church in the future. Despite these assets, Cindy has a long history of feeling reluctant to discard possessions. Her marriage to her now ex-husband, Dan, deteriorated, and after they divorced, Cindy started storing her possessions, which included a variety of items like holiday decorations, clothes, shoes, and plastic food storage containers. She reported that the divorce was devastating and created a sense of identity confusion and loss, which led her to question her own self-worth. Cindy was referred for counseling after Dan informed Child Protective Services. I think the case of them will actually mean references Child Services or Children's Services. In Virginia, we call this Child Welfare Agency, Child Protective Services. And Dan made a report to CPS that one of their children had injured herself while slipping on papers, falling down the stairs, and incurring a concussion. Cindy reported that she feels guilty and responsible for the problems she has caused her family, and motivated to change and committed to the counseling process. And she reported the following information unless otherwise noted. You may have noticed in the feedback to your own wikis at this point, I'm wanting to support you as you apply these social economic status data to sort of perhaps enhance the context in which you view your clients. In this case, Cindy is a stay-at-home parent. No concerns were reported regarding economic resources. There were no concerns reported about having access to housing, food, or other basic necessities related to financial means, which I think if I were to modify this paragraph in real time, I would add that this seems to add the context that her interest in conserving resources seems to not quite match her socioeconomic status. In other words, she doesn't seem to need to conserve resources to the extent that she is, or put or take risks with food safety to the extent that she is, given the fact that there are very few, if any, concerns about her access to housing, clothing, and nutrition for herself and her children. As far as presenting problems, I noted the hoarding type behaviors first. A collection of excessive possessions has gradually cluttered Cindy's home following the divorce. Bags and boxes have been piled high in every room. And they have left her with only a small pathway to access adjacent rooms. Several rooms in Cindy's home are inaccessible because of the clutter. She sleeps among newspapers and books, and she has accumulated in her bed. She goes to the local grocery store on a daily basis to pick up multiple newspapers from the previous day. She's also extremely fearful of not having enough food, so she also keeps her basement stocked with a large amount of food in case of a major weather event. Much of the food stored in her basement and refrigerator has expired, but she feels like she is being wasteful if she discards any of it. Her refrigerator is filled with moldy and rotting food, and her children complain about being served, quote, rotting food. CPS has been involved with the family to investigate and remediate concerns about the clutter in the home, putting Cindy's and the children's safety at risk. Nevertheless, Cindy is extremely indecisive. She not only finds it difficult to part with her old school papers, her children's baby clothes, and other sentimental items from the past, but she has difficulty deciding what should be discarded and is fearful that she will need that item in the future. Of course, there are safety concerns. In addition to Cindy's children complaining about eating rotting food, Dan, concerned that the clutter was a fire hazard with children living in the home, contacted Children's Services. However, before the visit, Cindy hid some of her possessions in the attic, crawl space, and garage. The social worker dismissed the case at that time, but 2 years later, Cindy's ex-husband called CPS again after one of the children slipped on some papers and fell down the stairs and was taken to the hospital. There are additional risks to her social connections. So Cindy lacks social support. In the past, she was actively involved in her local church and played the organ for the congregation, but she has not done that for a few years. She'd like to get more involved in her church in the future because her Christian faith is important to her. When her children ask to get rid of things so they can have friends over, the thought of discarding possessions fills Cindy with intense and overwhelming anxiety and prevents her from taking action. Cindy has cleaned her home for 2 of her children's graduation parties by moving possessions to the upper part of the house where the clutter would be hidden from guests. However, despite firm resolutions to keep tidy, the house became cluttered again within a week of those graduation parties. So relevant history includes her reluctance to discard possessions for as long as she can remember. She struggled in adolescence, even though her parents were extremely strict and forced her to keep a tidy bedroom. During adolescence, she would often hide her possessions, such as papers, drawings, and dolls under her bed or the back of her closet. When she married Dan, she maintained an uncluttered home in order to appease him. However, when Cindy's marriage deteriorated and Dan divorced her, Cindy started storing her possessions again. And no concerns were reported regarding Cindy's cultural history or identity, educational and vocational history, or medical history. No health practices were reported that might serve to mitigate her hoarding habits. No concerns related to suicide or self-injury reported. No additional medications, substance misuse, or family health concerns were reported, she appears to remain under investigation or monitoring by CPS in order as her hoarding behavior is resolved. This is sort of an alluding to legal status concerns. So as you might have guessed at this point, a accurate diagnosis for Cindy with the information available would be a hoarding disorder with excessive acquisition. To this clinician, Cindy's narrative includes persistent difficulty with parting with possessions, which is criterion A, distress associated with parting with them, criterion B, amassing possessions to the point that her living space was cluttered and compromised, and the hoarding has led to impairments with her ability to meet her and her children's basic needs for healthy food and general safety. No other medical conditions were reported, nor were symptoms reported that may be better explained by another disorder. Major depressive disorder was considered due to Cindy's difficulties socially, as in, for example, losing connection with her church, perhaps due to a loss of interest. However, no other symptoms were reported in the history of hoarding behavior long preceded any other condition or concerns. So the compulsive disorder was considered due to the obsessive and compulsive nature of the hoarding behavior. However, no fears or contamination, for contamination, harm, or feelings of incompleteness were reported, which are more characteristic of more typical obsessions and or compulsions. In terms of the neurological and biological considerations, hoarding disorder, like other obsessive compulsive type disorders, typically manifests during childhood or adolescence. It is often a response to developing a sense of order or control and to address a sense of disempowerment or chaos in the environment. This may, I think, be evident in the overly strict environment that Cindy grew up in, and then which then manifested itself again in adulthood during her marriage. SSRIs and SNRIs have been shown to be effective in reducing the severity of symptoms of hoarding disorder. However, counselors should consider that those dealing with hoarding type symptoms may be especially prone to losing medications in a cluttered home, thus leading to challenges with reliably participating in medication prescriptions. So it's important to emphasize in this case the importance of psychotherapy in the event that psychiatric medication management is part of a client's treatment plan. So that is sort of a case example and kind of walking through it in terms of our wiki and case vignette assignments. Hope you find that helpful. Looking forward to your questions and comments in the discussion board. And I look forward to seeing you at the next video about trauma and stress-related disorders.